My name is Dr. Sonali Smith from the University of Chicago. I want to thank the organizers for a chance to talk to you about non-Hodgkin lymphoma. In particular, I've been asked to talk about aggressive B and T cell lymphomas, and that's what I'll try to cover after a little bit of a background. So, at its core, what is lymphoma? Lymphoma is a family of blood cancers derived from cells called lymphocytes. These specifically are called B cells, T cells, and NK cells. And as many of you know, these are part of our immune system. Their job is to fight off viruses, bacteria, fungi, and other foreign organisms, and they have access to the entire body. They travel both within the blood as well as a special system called a lymphatic system. With this, they have access to nearly every organ, including the brain and other what we consider protected sites. They can set up shop and grow in lymph nodes, and we call that nodal, or they can grow outside lymph nodes, and we call that extranodal. When we think about the 1.8 or 1.9 million cases of cancer that are newly diagnosed in the United States per year, we know that non-Hodgkin lymphoma currently ranks as the 7th most common cause of cancer in both men and women. We've made a lot of progress, but what the bottom two charts show is that it still remains in the top 10 causes of cancer death, and clearly a lot of work remains. However, if we translate this, there's 80,000 new cases per year with 20,000 people who die from lymphoma. But the difference between the incidence rate and the death rate means that there's over 500,000 people living with lymphoma. And whenever I look at this number, it reminds me that I have to think about not only my short-term goals, but also the long-term goals associated with treatment, because fortunately I will know many of my patients for a very long period of time. Importantly, Hodgkin and non-Hodgkin lymphoma occur in both genders, all ages, and all races. This can even occur in children and is one of the more common causes of cancer within children. When we come to what causes lymphoma, we don't really know that specifically for individual patients. However, in general, there are a couple of risk factors. One is increasing age. So although I just said that lymphoma can occur in children, the median age at which it occurs is usually in the 6th decade of life. We also know that abnormalities of the immune system increase the risk for developing lymphoma, and this could either be inherited, related to treatment of another condition. For example, sometimes people with autoimmune conditions will get medications that suppress their immune system, or people who have had an organ transplant may be put onto anti-rejection medications, and these have been associated with a slightly increased risk of developing lymphomas. Or it could be acquired abnormalities such as HIV, which typically affects your lymphocytes and makes you lose your T cells. There are also some viruses that have been known to cause lymphoma, including hepatitis B and C, human herpes virus 6, and there are also chemicals and bacteria. When it comes to chemicals, this is somewhat drawn from the observation that some lymphomas occur preferentially in industrialized countries, particularly in the Farm Belt. It is very difficult in an individual person to say that a specific chemical caused that person's particular lymphoma, but certainly these are trends that we observe, and more research is necessary. The other aspect is that there may be an inherited component to why somebody develops lymphoma, and more, if you ask, we realize that people with lymphomas have family members who either have other blood cancers or other types of cancers. The effect of the environment, diet, and lifestyle also remains under investigation. When we combine all of those, the family of lymphomas from B cells, T cells, and NK cells, it turns out that there's more than 80 different types of lymphoma. And this makes it very important when you're talking to your doctor to make sure you understand what type of lymphoma you have, because as we'll discuss over the next few slides, your prognosis, your treatment all depend on specifically what type it is. The two most common types of lymphoma are diffuse large B-cell lymphoma and follicular lymphoma, but there are a number of other subtypes that we see fairly often. Another way to slice the pie, and this is a question that comes up all the time, is that we tend to make this family of non-Hodgkin lymphomas, we usually are referring to B-cell lymphomas because they are the more common type. However, you can also slice the pie and say, okay, T-cell lymphomas are separate and NK cell lymphomas are separate. I will also get questions as to what's the difference between Hodgkin and non-Hodgkin lymphoma, and you can see sort of the relative frequency in this cartoon. Non-Hodgkin lymphoma is about 10 times more common than Hodgkin lymphoma. Biologically, they are cousins. They are both cancers of B cells, but they have very different appearances when we look at them underneath the microscope, and their treatment is also very different. So the topic that I was asked to cover is aggressive lymphomas. So the question is, what is an aggressive lymphoma? Out of those 80 or so types of lymphomas, we tend to group them into lymphomas that either grow slowly and tend to be more like a chronic disease, those that grow more quickly, those are aggressive lymphomas, or ones that grow very quickly, and we call those highly aggressive lymphomas. For the purpose of this talk, I'm combining aggressive and highly aggressive, so if you hear those terms, that's what I'm referring to. So in general, an aggressive lymphoma is something that grows quickly and needs treatment either urgently or emergently. This is something where people don't feel well. They come to their doctors and say, I'm losing weight, I have pain, I have lymph nodes that are growing, or there's some other organ that is not functioning properly. Although this can be very urgent and very scary, on a positive aspect, many of these faster-growing lymphomas do respond to chemotherapy. Chemotherapy is a name for drugs that tend to kill cells that are growing quickly and tend to be pretty effective in many of the aggressive lymphomas. Some examples of aggressive lymphomas are listed here, including the most common lymphoma, which we're going to talk about, diffuse large B-cell lymphoma, but there are also some other variants here, such as high-grade B-cell lymphoma. You may hear the words double hit or triple hit, Burkitt lymphoma, mantle cell lymphoma, and something called peripheral T-cell lymphomas, which I'll cover in just a moment as well. So before I jump into the treatment of aggressive lymphoma, I just want to provide a few general principles as to how we approach lymphomas. So as I already said, it's really important to know exactly what you have because the treatment depends not really on the stage. So very different than what we call solid cancers like lung cancer, breast cancer, or colon cancer. Unlike those cancers, in lymphoma, which is a blood cancer, it's the type of lymphoma that decides how the treatment is going to go. We then take into account how old somebody is, how quickly the disease is growing, and whether or not they have any symptoms related to their disease. With this, we have two lymphomas, diffuse large B-cell lymphoma and Hodgkin lymphoma, where when we first meet somebody, the goal of treatment is cure. On the other hand, there's a disease called follicular lymphoma, which tends to be more slow-growing, and although we can treat it when people need treatment, we can't technically cure it. However, it's something that grows so slowly in the vast majority of people that it is something they live with, often for decades at a time. T-cell lymphoma and mantle cell lymphoma are more aggressive lymphomas where the goal is really to get the disease under control and see if we can have prolonged disease control and help the patient feel better. So depending on the goal, the type of treatment changes. So for diffuse large B-cell lymphoma and Hodgkin lymphoma, we tend to use aggressive chemotherapy and sometimes even a stem cell transplant. For patients with follicular lymphoma, where we know we cannot cure the disease, we tend to use less aggressive therapies, such as sometimes no therapy at all, sometimes monoclonal antibodies or targeted agents, and occasionally use chemotherapy. For T-cell lymphoma and mantle cell lymphoma, because these are more aggressive, we tend to use more aggressive chemotherapy and often use a stem cell transplant if a person is young enough and healthy enough to go through that. So I'll focus on diffuse large B-cell lymphoma first. So this is the most common lymphoma we see. It peaks in the 6th decade of life. This is what it looks like underneath the microscope. There's just sheets of these cells that are relatively large. If we don't treat this disease, people get very sick and sometimes don't survive. On the other hand, if we do treat, we can cure a significant portion of people. One thing that's really important to know is that the likelihood of cure depends on the subtype of diffuse large B-cell lymphoma. So it turns out that although this is the most common lymphoma, it's also an umbrella term. And there are many different types of diffuse large B-cell lymphoma, some of which are listed here. And this is something that you should talk about with your doctor so you know exactly what subtype you have. So when we think about diffuse large B-cell lymphoma, not only are there these different variants that I showed you underneath the umbrella, but it turns out that biologically these are at least two different diseases. And so this right here, some of you may have seen this. This is something called a heat map, And it is, another way to say it is gene expression profiling. So what we've known for diffuse large B-cell lymphoma is that we can cure a good portion of people. And the likelihood of cure sometimes depends on the underlying biology. What this heat map shows us is whether or not a gene is turned on or turned off. And each column here is a patient, and each row is a gene. And what's important, just to take away from this picture, is that there are multiple different patterns. And in fact, there are two main patterns here, one of which is called activated B-cell type diffuse large B-cell lymphoma, and the other one is called germinal center. So why is this important? It's important because if you have one of these fingerprints, if you will, of genes that are turned on and turned off, you have a slightly higher chance of cure, whereas if you have the other one, we know that our standard chemotherapy may or may not be enough. The other piece that we now know about this type of aggressive lymphoma is that sometimes there are chromosomes that are abnormal. So there's a chromosome called MYC, M-Y-C, and this chromosome, or this gene, I should say, this gene is something called a transcription factor, and it controls whether or not other genes are turned on or turned off. In general, whenever it turns a gene on, it causes the cell to grow. We call that proliferation. Often in diffuse large B-cell lymphoma, we will see this MYC gene rearranged along with another gene called BCL2. And what BCL2 does is it keeps these cells alive. So here you've got an accelerator, MYC, and you've got a brake, BCL2. And what that means is that these cells are growing and then they are failing to die, even with chemotherapy. And we call this double hit lymphoma. The reason this is important is that if your doctor notices that this is occurring in your diffuse large B-cell lymphoma, the treatment may need to be changed so that we can cure a higher percent of people. So in terms of the initial treatment then, I just put here some of the regimens that we use, or the recipes, if you will. So for diffuse large B-cell lymphoma, we most typically use a combination of 5 drugs that we call RCHOP, R-C-H-O-P, with each letter standing for a different drug, for either 4 or 6 rounds of therapy. If you have a higher grade B-cell lymphoma, which means that underneath the microscope it looks as if it's growing even more quickly, or perhaps has that double or triple hit biology that we just talked about, then we might want to use something a little bit more aggressive. And if you have an aggressive B-cell lymphoma called Burkitt lymphoma, then again, RCHOP is not enough and we need to use something more intense. And what's really important is that radiation and surgery by themselves do not have a role in how we treat people with non-Hodgkin lymphomas, and particularly with diffuse large B-cell lymphoma. So what if the disease doesn't respond to the chemotherapy, or it responds and then comes back? What are our options? Well, we take into account whether or not the disease comes back early or late, or whether or not it didn't respond at all, and then we decide whether or not somebody is a candidate for aggressive treatment or not. If somebody is a candidate for aggressive treatment, we try very hard to get them to something called an autologous stem cell transplant, and you've heard about that in this symposium. Another emerging therapy that I'll talk about in a moment is something called CAR-T. So if somebody is a candidate for this type of aggressive therapy, we have several different options. If somebody is not a candidate for aggressive treatment, and this might be because they have other organs that don't work, or they may have a lot of other symptoms, or they may be a little older, then we have other options that are less aggressive, but my very strong recommendation in this situation is that people consider a clinical trial. So what is an autologous stem cell transplant? So an autologous stem cell transplant is based on the concept that more is better. And by more, we mean more chemotherapy. We know that with many lymphomas, the more chemotherapy you give, the more lymphoma you can get rid of. But the downside is that the bone marrow, which is the liquid part inside your bones, and it's a factory that makes everything that travels in your blood, all your red cells, white cells, and platelets, can't handle the very high doses of chemotherapy. So in an autologous stem cell transplant, we take a person's stem cells ahead of time and we bank them, and then we give high doses of chemotherapy to get rid of every last bit of lymphoma and then rescue people with their own stem cells. So specifically, there are 4 parts to this autologous transplant. The first is to try to get the lymphoma into remission with something called salvage chemotherapy. The second is to collect those stem cells so that you protect them. The third is to give the high doses of chemotherapy and then rescue the person's bone marrow with their own stem cells. And then afterwards, we typically have a recovery period as well as immunizations. We know that an autologous stem cell transplant is effective in a portion of people with aggressive B-cell lymphomas, but it works best if the disease, if the lymphoma responds to the salvage chemotherapy. If a person is not in a complete remission, the autologous transplant has less of a chance to work, and we typically don't recommend it. It's also helpful if there's no involvement of the bone marrow, so no lymphoma in the bone marrow, and the patient must be in good condition to receive the very high doses of chemotherapy. In contrast, this CAR T cell therapy, which is much newer, just FDA approved in 2017, has some important differences. With a CAR T, instead of taking a person's stem cells, we take their T cells. And what's really important is that we actually don't need the lymphoma to be under control. In fact, it's even helpful if there's a little bit of disease there because these T cells are looking for their target. And I'll show you that in a cartoon in the next slide. The other advantage to CAR T cell therapy is that we use less chemotherapy than an autologous stem cell transplant, and this is essentially a living drug. Once we take these T cells from somebody, engineer them and give them back to the patient, these cells live forever, and they should recognize any lymphoma cells coming back, wake up, and start killing that leftover lymphoma. There's also some different risks of a CAR T cell therapy. The two common ones are listed here. One is called cytokine release syndrome, and the other one is neurotoxicity, and I'll explain that in just a moment. So how does the CAR T cell process work? Well, we start up here. We have a patient who has lymphoma that is not responding to other treatments, typically diffuse large B-cell lymphoma, which is that, or mantle cell lymphoma, which are the two lymphomas in adults for which this is FDA approved. We take T cells directly from the blood, and these cells then get engineered in the lab where there is a gene that is inserted so that this T cell now has these little spikes on the surface. What these spikes do, once they grow and you give them back into the patient, is that these spikes on their outside recognize a protein that lives on the lymphoma called CD19. Once it finds that, these T cells expand, and sometimes they massively expand and can cause some types of side effects that we associate with the flu, for example, high fevers, low blood pressure, sometimes shakes or chills, sometimes needing to go to the ICU. These are symptoms that are associated with something called cytokine release syndrome. If I blow up those little spikes, it's shown on this picture right here, so this is the T cell membrane. So the spike on the outside, this is what binds to CD19, and then on the inside is something called a co-stimulatory domain that only activates if it finds its target. So what ends up happening is that, if you look over here, is that once the T cell sees its target, it then binds, these T cells expand, and ends up causing death of the cancer cell. CAR T cell is a very exciting area. It's now FDA approved, as I was saying, for both diffuse large B-cell lymphoma and mantle cell lymphoma, and it seems to work even when people have leftover lymphoma and does not rely on the high doses of chemotherapy. Exactly where CAR T cell therapy is going to end up and how we treat people with lymphoma, with diffuse large B-cell lymphoma, I think is in evolution, but as of right now, it's FDA approved for people who have had at least 2 lines of chemotherapy. I'll switch now to T-cell lymphomas. So if you remember from the pie, T-cell lymphomas are much less common. So about 85% of all lymphomas in the United States are B-cell, and only about 10 to 15% are T-cell lymphomas. And you can see that again here in this pie. Complicating the picture is that when we look at this 12% or 10 to 15% of T-cell lymphomas, it's actually another whole family of diseases, and there's at least a dozen different types of T-cell lymphomas, the vast majority of which would be considered aggressive lymphomas, meaning that they grow quickly. Unfortunately, T-cell lymphomas tend to be more resistant to chemotherapy. And so instead of just giving chemotherapy up front and seeing if we can cure a portion of people, in general, we have to give chemotherapy and then follow it up with something called consolidation. So the chemotherapy recipes that we use are listed here. Here's a couple of them. And the consolidation is usually that autologous stem cell transplant. So you'll remember that with the B-cell lymphomas, we wait until the disease comes back before we use stem cell transplant, whereas in T-cell lymphomas, we use it right away. If a T-cell lymphoma comes back, we may consider patients to go through another type of transplant, such as an allogeneic stem cell transplant, but really this is where it's important to consider a clinical trial. There are some other options that are FDA approved, including giving more chemotherapy or trying some of these non-chemotherapy approaches that are listed here, but in general, this is an area that we need to continue to study so that we can find the best treatments. So in summary, aggressive lymphomas are a complex family of blood cancers. It's really important to know what we're dealing with. So a good biopsy is critical for management. And as we discussed, it's the type of lymphoma that's much more important than the stage. For an aggressive lymphoma, treatment usually needs to start quickly. But on a positive note, many fast-growing lymphomas, particularly the B-cell lymphomas, do respond to chemotherapy. And if chemotherapy doesn't work, we have good second-line and third-line options that are continuing to take hold and take shape within how we take care of patients. So there are many new treatments based on better science, and certainly hope that this applies across the board to our aggressive lymphomas. So with that, I'll stop and wish I could take questions, but appreciate your attention. Thank you.